Saudi Gastro Association for inviting me here to Jeddah. It's been a huge honor, and I've been met with friendship and a few amusing encounters. So thank you very much. It's wonderful to be here. What I'm aiming to do, first of all, is illustrate the consequences of unwarranted variation in quality. It's very important to start with that, because if you're going to do something different, you have to persuade someone that there's a problem to start with. I'm going to explain how we view and define high quality, explain the concepts of quality improvement and quality assurance, and describe the journey we've made in England in the last 25 years. And I'll just finish with a couple of recommendations for Saudi. So whichever healthcare system you look at in the world, and as far as I can make out from my discussions in the last 24 hours, it's the same here in Saudi, is the expectations are running away from what we can deliver. And particularly if I think about this country, it's a very young country demographically, and that demographic is going to age, and with it you're going to see a lot more gastrointestinal cancers than you're currently seeing. Now, that's the bad side of the coin. The good side of the coin, remarkably, is that there's a lot of what I'd call unwarranted variation in healthcare. And what that means is that this is variation which can't be explained by a demographic or some other factor. And this histogram is of either provider hospitals, services, or individuals. And whatever you look at in healthcare, whether it be post-hip fracture, infections, or bleeding from esophageal varices, or hepatitis B treatment, you will see variation in outcomes which is unwarranted. And the flip side of that is that there is something here that you can do something about to save money and to improve outcomes. Now, that curve is taken from post-colonoscopy colorectal cancer occurring within 3 years in English NHS hospitals, and we published this a couple of years ago. And basically, we're seeing rates from somewhere like 4 to 5% up to 12 or 14%. My hospital is right over there on the left. We're in the top 10th centile. And we did a review of our cases a few years ago and published it. And we deemed 89% were avoidable. So I think potentially we could get rates down to 2%, let alone 8 or 14%. How big is the problem? Well, in England, there are probably 1,400 people a year who have a post-colonoscopy colorectal cancer occurring within 4 years. Some of these will be data errors, but 300 are likely unavoidable. So the patient was too old to have further endoscopy or whatever it might be. That leaves potentially 1,000 patients every year who had a preventable post-colonoscopy colorectal cancer. Now, some of those will be late diagnosis, and some of them will be new cancers. Now, 4 years is an arbitrary limit, and if we look at this study that was published a few years ago, we're looking at the adenoma detection rate in a randomized controlled trial of flexible sigmoidoscopy for colorectal cancer screening. And the red are the low adenoma detectors, and the green are the high adenoma detectors. And at 17 years, we can see quite a spread in the cumulative incidence of cancer. And we also see a difference in colorectal cancer mortality. So something's going on there. And these authors did some calculations of the number needed to screen to prevent one cancer and prevent one death. And basically, we're looking here at maybe 10 lists to prevent one cancer with the high detectors, and 12 or 13 lists for the low detectors. So quality really, really makes a difference. Now, there have been several studies from different parts of the world, and it won't be any different in Saudi. You just don't know about it yet because you haven't measured it. If we look at this study from Kaiser Permanente in the west coast of America, we're looking at quintiles of adenoma detection here, going from bad to good, and we're looking at risk of advanced cancer and risk of fatal cancer. And basically, if you're scoped by a good colonoscopist, your risk of cancer is about 40%, and your risk of dying of cancer is about 40%. So a very, very big difference. Second point of this slide is this is a problem in North America as well as in England, and we see similar data coming from Poland, Belgium, Holland, Denmark, and Sweden. Now, we published a study this year looking at the cost savings of improving the top 2/3 of the country to the bottom 2/3 of the country if they achieved the same rate of post-colonoscopy colorectal cancer as the top third. And basically, we estimated we'd save about $6.5 million a year. Now, as I said earlier, we could probably get it down to 2% if we really tried. So there are massive savings to be achieved. Now, this is a health economic diagram, and we're looking at any intervention you have in healthcare can be put on this diagram. Most interventions cost something, and they achieve an outcome. If the outcome is a negative outcome, it would be down below here, and if you actually saved money by implementing the outcome, it would be over here. And we look here at a low quality outcome at higher cost versus a lower cost procedure with a higher outcome. And this is where the good PCRC sits, and this is where the bad PCR sits. Now, the point here is that we can save money if we do things properly. And the cost of improving the quality is an absolute fraction of the cost of the bad quality. So just let's look at these slides here. So this is a procedure that was done by a colonoscopist in our service who's regarded to be very good. And he took these pictures of the cecum, and he found a few polyps on the right side of the colon here, And basically, he spent a time removing these polyps, but he didn't mention the sessile serrated lesion in the cecum. He just hadn't seen it. And I happened to do a colonoscopy a few weeks later, and these are my pictures, and we can see here that there is what we call a sessile serrated lesion, and within it there's a bit of adenoma. And this is a very high-risk lesion that this colonoscopist had missed. He took all the big polyps out, but this thing is quite dangerous, and if it's not removed, could lead to colorectal cancer. Now, it doesn't cost any money at all to do that colonoscopy properly. Okay, we spend a little bit of time removing that lesion, but actually finding it costs nothing. It just requires you to look. Now, do we have a problem with upper GI endoscopy? And here's a slightly different illustration of the frequency of upper GI cancer appearing after a negative OGD in relation to the number of cancers that are diagnosed in all these different hospitals. And a couple of things to note is the average rate of this metric is 8.5%, and that means 1 in every 400 endoscopies is missing a cancer or failing to prevent it. And the other thing is we have quite a lot of hospitals, either 2 or 3 standard deviations from the mean. Now, we believe that this cluster should be down here somewhere, and there's a chance to improve the quality of upper GI cancer as well. Now, if you don't think you've got this problem in this country, I would say that you are probably wrong. You just don't know because you haven't measured it. Now, we did a very large audit of these cancers in 143 hospitals in England, 2,666 cancers. And what we did is basically the services where the cancer occurred did a review, a root cause analysis with a structured template where I asked lots of questions about why the cancer had appeared, why it was missed. And 45 endoscopies were deemed inadequate. And these were the sorts of problems that we found: poor photo documentation, poor management decisions, poor biopsy practice, failure to complete the procedure, poor tolerance, etc. So there's a lot of room for improvement in what's going on in England at this moment in time. And I would say you don't know that there's a problem in this country because you haven't measured it. And if you did, you'd find these problems. Now, the focus I've made up until now is really about the quality of the procedure. But the procedure just occurs in the context of a service. And there are many other aspects to the service which are more than the actual quality of the procedure. Clearly, the quality is very important. But when we're looking at quality, we need to think of different people's perspectives. The patients haven't got any idea of the quality of the procedure. If they are met with a friendly face and they don't have to wait very long and they get a nice cup of coffee and something to eat afterwards, and everybody, they give lots of good information, they might have had a terrible endoscopy, but they think the whole experience is fantastic. The health ministry needs some education on what we need to look at, but they will have their own view on what quality is. Now, we have looked at what we call performance measures in the ESG, and this was published about 6 years ago. I led this piece of work, and here we see 2, 4, 6, 8, 9 domains of quality and various subdomains here. Now, you can't read all this, but if you're interested, I'd encourage you to look at this document. 10 years ago, I was asked to develop a strategy for accreditation of all services in healthcare. That's every single service in healthcare. And we created a generic standards document published with our standards body in the UK called the British Standards Institution. These are the people that create ISO standards, EN standards, etc. And anybody interested in this, I urge them to have a look at this document here, because it really looks at the whole aspect of healthcare, including strategy management and looking at things like improvement, innovation, and transformation. Now, within endoscopy in the UK, we are using the global rating scale, which I'll explain in a minute, and we have an accreditation system. And talking to the leaders of the association here, there's interest in creating this in this country. So it's worth spending a few minutes thinking about that. There are other standards. We published, I led this piece of work, an EU guideline on quality assurance in screening programs of colonoscopy, and I've been involved in the ASG and the Canadian Association of Gastroenterology guidelines as well. Now, if we wind the clock back in the UK about 20, 25 years, it was pretty bad. From a patient perspective, it was pretty awful. There was no privacy and dignity. They had to wait long. They had to wait ages or never got the results of their biopsies. There were complications occurring. For example, one of my patients, believe it or not, well, not my patient, but in my unit, one of my colleagues put a peg in the wrong patient. I mean, can you believe that? All right, so I had to go and speak to the patient afterwards and apologize for the fact that he had a tube in his stomach that he didn't need. So it was pretty bad. And the waits were very, very long. And around the same time, we have something called the National Confidential Inquiry on Perioperative Deaths. And they had looked at deaths that occurred within 30 days of a colonoscopy and wrote this report. And the content of the report was truly shocking. All sorts of things were happening. Patients were dying unnecessarily. And again, it's worth reading if you're interested. Now, I would like to point out that around this time, we got some money from the government, both to improve training and modernize the service. And that money was got on the back of all this bad news that was spilling out at that time. And for modernize, we have, what that means is reducing waiting times and being more efficient. Now, I had a budget. I was made National Clinical Director at that time. I had a team of people. I was able to appoint a regional lead who got a half a day a week to work with us. We had 10 national training centres with 10 leads and 10 nursing leads. So I had an army of about 48 doctors and nurses to help me. I was dealing with the professional bodies, the Department of Health, and of course the frontline teams. And I used to go around England around that time, and I'd be in meetings like this, small meetings, big meetings, and I'd put up a flip chart, and I'll ask the endoscopy staff to tell me what they think constitutes a good experience for their patients, their staff, and for training. And essentially, we came up with these items in 4 domains. You know, we thought the procedure should be appropriate. We thought patients should give us feedback. We needed our trainee endoscopists to have qualified trainers, and we wanted some feedback from our staff about what it was like to work in the unit, for example. And what we did is we had each of these things were underpinned by descriptors, which is basically you have to achieve it's like a checklist, which would evidence whether you had achieved a reasonable standard. And we called this the Endoscopy Global Rating Scale. Now, to be honest, when we created this, I thought it might last a year or 2, and we're now 21 years later, we still have the Global Rating Scale, and that tells you a bit that people regard it to be useful. Now, in the beginning, there was a lot of pushback from doctors particularly, and this is a quote from one. When I first saw the GRS, I have to be honest and say that I printed it, read it, ripped it up, and chucked it in the bin. I had no intentions of ever doing anything with it. Slowly, I saw what was going on around me, and I had another look. I now truly believe that it's been the single most important thing that has helped us to improve our service. I feel somewhat embarrassed at my initial reaction. And that was written about 20 years ago. Now, what we're looking at is closing the gap between what would happen if we did nothing and what we're trying to achieve. And what we found was self-assessment against this global rating scale lifted the service up, or that's what they told us. But not all services were able to respond, and I asked my regional leads to go into their services between 6 and 12 in any region and work with the endoscopy units to help them achieve the standards, but also to check that their reporting was accurate and they weren't cheating. And we required each unit to self-score in a web-based portal every 6 months. And this is the results of those scoring, where we have a scoring rate of between A and D, where A and B is a good standard, and the percent scoring A and B, you can see rapidly rose to high levels. And if you look down the bottom here, this is the percent compliance with scoring online, so always in excess of 95%. So it meant all the services were participating in this. And around the same time, the waiting times in endoscopy, and remember there were 250,000 waiting, so the top of this curve was somewhere on the ceiling, and the waits were coming down to virtually nothing during this period. So we add a little bit if we have peer review to this self-assessment. What more can we do? Well, what we then added was a formal accreditation process, and this is the accreditation pathway that exists today. And basically what happens is a service has to go through some quality improvement cycles and has to upload evidence, which is assessed online, and then there is a visit by a team, and you are awarded accreditation if you meet all the standards. And there's an annual renewal process, and the whole thing repeats at 5 years. And that is what's happening now. So basically, the assessors were using the global rating scale with a few other things to go in and see whether the services were achieving all the standards within the scale. And so accreditation has lifted the service to reach the standard. And if you speak to anybody in the standard, they'll tell you a couple of things. One, that it's been, well, 3 things. One, that it was hard work. 2, that it gave them huge kudos, huge recognition. 3, that they wouldn't want it to not be there, even though it was hard work and a nuisance. It really empowered them to get the resources they need to provide the service. So what else has happened? Well, we've implemented a screening program with very high quality indicators. We created a national endoscopy database. We had creation of some, recently of some training academies. We've done huge national audits, this one showing in 2011 that we'd corrected the very bad colonoscopy performance published a decade previously, and we are looking at productivity. What about the training? Well, my colleague John Anderson and I have been around the world training different countries to develop training programs with varying degrees of success. And that success really depends on how well structured the local environment is and how well it's led. So if we take Canada as an example, we taught them how to train colonoscopy, to do it properly and to train it properly. And on the back of our work, they created this Skills Enhancement for Endoscopy program, which has been very successful and has been in place for at least 10 years. And here's an example of a very successful response to our upskilling, if you like. But it isn't always like that. Scotland is interesting. I was in Scotland on Monday and Tuesday this week, teaching their senior polypectomists with my colleague how to do polypectomy properly and safely. And in Scotland, there'd been some audits of poor performance. They weren't engaged in accreditation. Their bowel cancer screening metrics were bad. They had long waits, and they had poor support from the ministry. However, the ministry stepped up and gave them some money to invest in service and training, and they had an excellent clinical lead, and they created a strategy for improving the quality of training in endoscopy. And my colleague and I went up there several times in recent years to bring them all up to speed with modern colonoscopy technique and to train their trainers and to train them to train polypectomy. And we used, and this is a bit of a plug, we have a portal which has over 1,000 videos, deconstructed videos of how to perform excellent endoscopy, not just colonoscopy, but OGD, ERCP, etc. And I would really encourage you to have a look at this portal. There is a small charge for full access, but it's just a few euros a month, and a lot of the Scottish endoscopists were using this portal on a regular basis, and they would quote stuff back to us that we had put into the portal. Now, the results of what happened in Scotland are nothing short of astonishing. Now, these figures may not seem extraordinary, but I tell you, I haven't seen an improvement like this in such short space of time anywhere. So we look at the cecal intubation rate has gone up to 93%, and the polyp detection rate has gone up an absolute increase of 14% on 31. I mean, that is a massive increase in polyp detection rate, and RR refers to rectal retroversion. So lots of things have created this, but overall there's been a strategy based on best modern techniques of doing the procedures and teaching the procedures. Now, I mentioned the National Endoscopy Database, and basically what happens here is every unit in the country has an electronic reporting system, and each electronic system has to upload key performance indicators to a national database. The system I use does that every night. So every night, all the procedures will be done without any patient identifiable information, so not the report, it's the data, goes up to the National Endoscopy Database. Now, different people have different access to the database, and I can have a look at my own performance. And I downloaded these images just 3 days ago, and this is colon, and each dot is one colonoscopist in our unit. And these are the number of colonoscopies done in the last year. This is for 2004. These were done by locum endoscopists who were just with us for a short while. And you see, I'm the red dot there. I've done about 500 colonoscopies with a cecal intubation rate of just short of 99%. And we have various lines on here for the organization average, the national average, and we have the confidence intervals around the performance of our own units. So I can look at that. My clinical lead, he knows the name of each of these dots here. so he can performance manage the colonoscopist in our unit. And here we have the polyp detection rate. This is me up here with a polyp detection rate of about 77%. And you can see that the polyp detection rate in our department is well over, is probably about 60%, which is very, very high, and well above the national average. There are a few outliers. And here, finally, is a table of my own performance, and I draw you attention, these are quarters. These are the number of colonoscopies I've done each quarter. My completion rate is sort of 98, 99%. My polyp detection rate is sort of 70 to 85%. And here we see I do more than a third of procedures without any sedation at all. My comfort levels are very acceptable. So down here, 3.3 is 3.3% of my patients will feel uncomfortable or to the level of pain. So the question is, can your country, can your association do any of this? And I've had conversations with various people, and I've heard a lot about what's going on in the country, and I would say absolutely, definitely, that this is achievable. It's not going to be easy, but it's achievable. And my own view would be, A, that this is something that needs to be controlled by the professional group, because if you don't do it, somebody else will, and you may not like what they do. And I think it better that this is done within the country. If I was you, I wouldn't want to be parachuting in foreigners assessing my units. So I think it's possible. Now, you have to think of a few things. So the first thing, I started my presentation on, there is a problem. I gave you some evidence of bad performance in my country. It's a lot better than it was, but there's still a way to go. Now, you may struggle to provide that sort of evidence, but whichever country you look at that does measure things, you see major problems, major unwarranted variation. And if you're going to persuade something on people that there's a need to change, you can use the proxy evidence from other countries. And it's inconceivable, I would say, completely inconceivable, that you don't have the same problems here. I don't mean that in a pejorative, critical way. It's just reality. It's extremely important to have strong clinical leadership and a desire to change. And that leadership needs to create a strategy, and you'll need some money, but you can shortcut a lot because you can just look at what others have done and you can just copy it. You don't need to reinvent the wheel and make all the mistakes we made, and we made a whole bunch. So clinical leadership is important, and recognition as acceptance that there's a problem is very important. So what about the money? Now, knowing what is required, I think the idea that you can just do this with a little bit of cash and goodwill is, I would dismiss immediately. You do need some serious funding for this. And you will, I would predict, get a lot of difficulty getting that funding, because governments in different countries have a habit of not really listening to the experts within the health service. We have that problem in our country, and they'd rather pay KPMG vast quantities of money to tell them what to do. KPMG will be employing people between the ages of 23 and 28 who've got no experience of healthcare, but they get paid vast quantities of money, and that's not really the way to go. So the way to go is to try and control this yourself. So you're going to need some money. Well, how much money did we spend? Well, if we go back right to 1999, really, it kicked off. And if we look at all the various sources of funding, and we had some money for training, for service delivery, the bowel cancer screening program, the little bits of money coming here and there, I've estimated this is about $30 million US a year. Now that sounds like a lot. Okay, $30 million, somebody gave you $30 million and said, go on with it, you'd be opening the bottles of champagne. Oh, no, you wouldn't, sorry, in this country, you wouldn't be doing it. You'd be celebrating, okay. So Now, but just think about how much money that is. So over 25 years, that's 50 cents for every person in England. And that's 2 cents for every person every year. And you don't even need to spend a fraction of that, okay? I wouldn't say how much money you need to spend, but you need some money, I would say, to make this happen. So I'll end there. I'm very pleased to answer any questions now or afterwards. Thank you very much.